Hello class, you've made it to week 6 in NUR715. This week we are covering feeding and eating, elimination, and sleep disorders in the pediatric population. This week we'll focus specifically on anorexia nervosa, bulimia nervosa, and binge eating disorders. However, eating disorders are also inclusive of pica, rumination disorder, avoidant restrictive food intake disorder, other specified feeding or eating disorders such as night eating syndrome or purging of small amounts, and then finally unspecified feeding or eating disorders. Here you can see the prevalence of eating disorders worldwide by age. And it's important to note that recently we've seen a spike in teenage females particularly of eating disorders. So you see that reflected here as the graph starts to show extension between ages 15 to 19. And then we know that eating disorders are very prevalent between your 20s and early 30s, so that's reflected here as well. And yet it starts to decrease in prevalence as you reach your 40s. And that is very reflective of what the literature shows us. It's not common to be diagnosed with new onset beyond the age of 40 for eating disorders. Here you can see screening tools utilized in child-adolescent age ranges as well as across the lifespan inclusive of pediatric patients to be able to identify disordered eating habits early on or even capture current eating disorder diagnoses. When we talk about anorexia nervosa, it's important to keep in mind the 3 essential features, the first being persistent energy intake restriction, the second being intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, and the third being disturbance in self-perceived weight or shape. Anorexia nervosa is more common in females than their male counterparts, usually occurring between the ages of 10 to 30, with a significant increase in incidence among 15 to 19-year-old females. It's usually brought to medical attention when weight loss becomes more apparent. The weight loss grows so profound that there's physical signs, including hypothermia, dependent edema, bradycardia, hypotension, the appearance of lanugo, and patients will end up showing a variety of metabolic changes as well. These medical complications warrant immediate attention, and oftentimes patients with higher severity of anorexia nervosa will have to be admitted inpatient. The severity of anorexia nervosa is based on the patient's BMI. There's also high rates specifically of comorbid depression with anorexia nervosa, and there is a high suicidality rate in the binge eating purging type of anorexia nervosa. Treatment considerations for anorexia nervosa in the pediatric population are very similar to the adult population. The goal is primarily medical stabilization, ensuring nutritional rehab, restoring weight, reducing the fear of weight gain in the patient, as well as improving their thoughts about their body shape and weight. Weekly weight goals are set during treatment, and if patients are unable to meet those weight goals, then the treatment plan needs adjustment. A higher level of care is needed if there is no progress in gaining weight after 6 weeks of treatment. Generally, the closer a patient is to their target weight before discharge, the less likely they are to relapse or have a readmission. And they are also less likely to relapse if they are able to maintain their weight for a period of time before discharge from either an inpatient or residential treatment center. If there was profound malnutrition, it's important to be aware of the signs of refeeding syndrome. And in order to prevent refeeding syndrome, frequent monitoring of labs is indicated, specifically testing for glucose levels and electrolytes such as magnesium and phosphorus, replacing phosphorus orally when indicated to prevent hypophosphatemia, which occurs often in these patients, ensuring there's adequate nutrition, and also monitoring these patients who are at risk for refeeding syndrome for signs of heart failure. Specific to the adolescent patient population, FBT is the first line of treatment. You can also utilize adolescent-focused therapy as well. Not very many studies have been done on medication management or produced positive results for medication management in the anorexia nervosa adolescent population. However, olanzapine has worked in some adult studies, and so you could utilize that for patients aged 13 and up. Risperdal could also be utilized. However, studies have not shown much impact in weight gain from utilizing it. Seroquel has shown some positive benefits for weight gain, so you could utilize that from age 10 and above. It's utilized between ages 10 to 12 for other diagnoses, so that would be possible in this situation as well. And then you could utilize Prozac as an SSRI to treat comorbid depression symptoms and hopefully lift mood, or even other antidepressants that could be indicated. Moving on to bulimia nervosa. This diagnosis has 3 essential features. They include recurrent episodes of binge eating, followed by recurrent inappropriate compensatory behaviors to prevent the gaining of weight, and self-evaluation that is influenced by one's body shape and weight, their self-image particularly. It's important to note that the binge eating and compensatory behaviors must occur on average once per week for at least 3 months. Bulimia nervosa is a disorder that peaks in older adolescence and young adulthood. Patients normally are within a normal weight range or potentially the overweight range. And there is a notable increase in risk for suicidality in bulimia nervosa patients. This is something very important to keep in mind when you move on to treatment considerations, specifically with antidepressant use in this population. It's uncommon to see onset of bulimia nervosa before puberty and again after age 40. There is diagnostic crossover from bulimia nervosa to anorexia nervosa in about 10 to 15% of clinical cases. And these patients often have comorbid mood and impulse control disorders. We did highlight the essential features of bulimia nervosa already, but it's important to remember that the criteria includes severity based on the number of episodes of inappropriate compensatory behaviors per week, and that can range from mild all the way to extreme. Again, treatment considerations for the pediatric population are very similar to that of the adult population suffering from bulimia nervosa, and severity is what guides the level of care that is indicated. The goals are to reduce binge eating, to reduce the compensatory behaviors that follow the binge eating. That can include self-induced vomiting, misuse of laxatives, or excessive exercising. And the final goal is to improve thoughts about body shape and weight in these patients again. Again, FBT is the first line of psychotherapeutic treatment for these adolescent patients, as well as CBT, and there are indications in the literature that DBT is helpful in showing good progress. That is specific to individual case studies, however. When we talk about medication management for bulimia nervosa patients, we know that Prozac is FDA approved in adults and can be utilized safely in the pediatric population. We also know that specific to binge eating, Vyvanse is FDA approved in adults, and Topamax has also been indicated to reduce episodes of binging, so it could be utilized safely in the adolescent population. Some things to keep in mind are the black box warning relative to Prozac and other SSRIs for adolescent patients, specifically this population, because bulimia nervosa, as we stated before, does carry a high risk of suicidality. We also know that there are concerns related to prolonged QT intervals with use of citalopram, so if possible, it would be wise to avoid. We also know that Wellbutrin is contraindicated due to an increased risk of seizure activity in this patient population, and you should avoid lithium to manage mood on account of toxicity risks. Coming to binge eating disorder, we know that that includes engaging in frequent binges, and patients are often doing this independent of feeling hungry. This must occur at least once per week for a minimum of 3 months. Binge eating disorder is associated with overweight and obese individuals. These patients are often already seeking weight loss treatments. They have high rates of comorbid mood, anxiety, and substance use disorders. We did highlight some of the characteristics of binge eating disorder, but let's review the DSM-5 criteria. Criteria A includes recurrent episodes of binge eating. This is characterized by eating in a discrete period of time an amount of food that is larger than normal, as well as a sense of lack of control over eating during those episodes. Criteria B shows that binge eating episodes must be associated with 3 of the 5 following: either eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of foods when not feeling hungry, eating alone because of associated embarrassment about the amount of food that you're eating, and feeling disgusted with yourself, depressed, or guilty after the episodes. Criteria C denotes marked distress regarding binge eating. Criteria D notes that binge eating occurs on average at least once a week for a duration of 3 months at minimum. The binge eating cannot be associated with the recurrent use of inappropriate compensatory behavior as in bulimia nervosa, and does not occur exclusively during the course of bulimia nervosa or anorexia nervosa. The severity of this disorder is based on the number of episodes of binge eating per week. Binge eating disorder has been understudied in the adolescent population, and so treatment considerations are based primarily in that of studies done on adults, very similar to bulimia nervosa and anorexia nervosa. But the one thing that is shared between all of these disorders is that FBT has great promise for child-adolescent patients. It is a wonderful first-line treatment, and with bulimia nervosa and binge eating disorder, the focus in FBT is mostly on addressing the feelings of shame and the secrecy and dysfunctional eating patterns that are associated with their disorder, while also trying to develop a collaborative relationship with the parents of these patients. We know that you could utilize Vyvanse for binge eating. You could utilize Prozac in order to treat the comorbid mood issues. And we also know that there are studies showing combination CBT plus SSRI use shows great promise and positive outcomes for these patients. Now we reach elimination disorders, which include enuresis and encopresis. Enuresis is repeated voiding of urine, day or night, into one's bed or clothing. You have to be age 5, either chronologically or in developmental level, before being able to be diagnosed. Most of the time, this is involuntary voiding of urine, but there is also accounts of voluntary voiding. Encopresis, less common, is the repeated passage of feces into inappropriate places, and one must be at least age 4 chronologically or developmentally before you can be diagnosed. So let's talk about the epidemiology and etiology of these disorders. Enuresis is found in about 5 to 10% of 5-year-olds. That drops down to 1.5 to 5% in 10-year-olds, and then drastically drops to only 1% in adolescents aged 15 years and older, becoming very rare at that point. It is more common in males. It's actually 50% more common in boys. And we know that about 75% of these children have a first-degree relative with the disorder as well. That points out a huge familial tie or genetic link to this disorder, so much so that a child's risk for enuresis is 7 times higher if their father was also suffering from this disorder. There are genetic, psychosocial, and neurobiologic causes to enuresis. Moving over to encopresis, we know that this is less common than its counterpart, and children with this disorder typically withhold their feces, and it is likely functional. About 90% chronic childhood encopresis is likely functional in nature. We know that it is in about 3% of all 4-year-olds, and then drops to 1.6% of 10-year-old children, and is essentially non-existent in ages above that. There is a lot of associated fear of defecation and withholding behaviors for children who have encopresis, and oftentimes there is complicated interplay between physiologic and psychological factors that end up leading to avoidance behaviors of defecation. We know that a history of trauma can also be linked to encopresis and also enuresis. So when we talk about diagnosing these disorders, you need to rule out medical conditions as differentials. So for enuresis, that could include recent psychological stressors, trauma, death in the family. It could include undiagnosed diabetes, epilepsy, ruling out UTIs, hyperthyroidism, obstructive sleep apnea, neurogenic bladder, or even enuresis as a side effect of medications. For encopresis, that means ruling out Hirschsprung's, spina bifida, chronic diarrhea, or even anal stenosis. You also have to differentiate between primary or secondary for these disorders. So primary would be the patient never established either urinary or fecal continence, and secondary means that this presented after a period of established continence. Enuresis has specifiers including nocturnal only, diurnal, which is during the waking hours, or a combination of the two, nocturnal and diurnal. For encopresis, the specifiers include with constipation and overflow incontinence, as well as without constipation and overflow incontinence. We already talked about some of the other DSM-5 criteria, which is also very specific to minimum age requirements as well. Treatment for enuresis should initially include reviewing appropriate toilet training for the patient. You could also try to restrict fluid intake before bedtime, and alarm therapy conditioning has positive outcomes. If those measures do not work, then you can move on to medication management. And there are times at which those measures are not feasible because of the patient's presentation. For instance, if they have a neurodevelopmental disorder, perhaps they cannot participate in these modifying variables. So if you move on to medication management, that's inclusive of imipramine, an antidepressant, and desmopressin, which we know is a synthetic antidiuretic hormone. So if you utilize imipramine, that is an off-label use of it. We do not actually know how it positively impacts these enuresis patients, but there is suggestion that perhaps depression is linked to behaviors of bedwetting. If you utilize this, also make sure you get a baseline EKG because there is risk of cardiac arrhythmias. When utilizing desmopressin, the biggest thing to do is monitor electrolytes because there's risk for water intoxication. And this medication could be used short-term or long-term, which is a nice benefit of it. Encopresis treatment also requires initial review of appropriate toilet training. It includes supportive behavioral interventions. You have to treat constipation. You could utilize daily oral administration of laxatives, and at times your patient may require disimpaction. Psychotherapy also has great benefit. For instance, CBT for associated anxiety, relaxation techniques because of the aversions that patients have, and then supportive therapy for self-esteem and subsequent social isolation that ensues with this diagnosis. Our final segment reviews sleep disorders in the child-adolescent patient populations. It's important to have a baseline reference of normal sleep parameters in children. So during the first year of life, you're aiming for about 16 hours of total sleep time. Then between 1 to 3 years of age, you're aiming for anywhere from 10 at minimum to 16 hours of sleep. 3 to 5-year-olds, again, they're hoping for anywhere from 11 to 15 hours, but it's important to keep in mind that about half of all 3-year-olds do not nap. So it is very difficult to reach that total sleep time requirement. And then as you get to 5 to 14 years of age, the length of time sleeping, total sleep time, is anywhere ranging from 9 to 13 hours. And above 14 years of age, then you are aiming for 7 to 10 hours of total sleep time. And napping at any age from 14 and above is indicative of insufficient sleep or potentially a sleep disorder. So that kind of clues you in on the things to watch for, or when patients are reporting how often they sleep or how much sleep they get in a night, compare that to these normal sleep parameters. Let's review the sleep cycle as well. There's 2 types of sleep, non-rapid eye movement and rapid eye movement. NREM sleep goes through 3 stages, N1 through N3. That continuum is made up of progressively deepening sleep, decreased response to stimuli, and intact muscle tone. You are in light sleep during N1 and N2, and then you shift into deep sleep in N3. NREM makes up a total of 75 to 80% of the night sleep cycle. Then there is REM sleep, which makes up about 20 to 25% of the sleep cycle. This is the stage where you are dreaming potentially, varying responses to stimuli are taking place, and there's voluntary muscle paralysis during this phase. You will typically go through about 4 to 6 sleep cycles in one night, and a cycle consists of the 3 NREM stages and then 1 rapid eye movement stage, REM stage. So that makes up 1 sleep cycle. These stages are critical to brain functioning and rest and recovery that helps your brain and body complete multiple functions essentially from day to day. So it's very important. And healthy transitions through these sleep stages are critical. Here you have some screening tools that you can utilize in your pediatric patient populations. At times you'll have to send your patients out for specialized assessments such as polysomnography, actigraphy. It's important to rule out any underlying causes for sleep disorders in your child-adolescent populations. That's because we know that sleep disorders are secondary in this pediatric population. Very rarely are they a primary diagnosis. We also are aware of familial and genetic indications. So very often genograms are warranted, and that helps in your assessment as well, because we know that sleep traits have a hereditary component, and those traits that are passed down include things such as timing of sleep, daily sleep requirements, how one responds to sleep deprivation, and even EEG variations that are found. So genetic testing helps to identify certain sleep disorders. For instance, narcolepsy is associated with a genetic mutation or variation of DQB1. We know that there are multiple genetic mutations and variations that we've already identified, and so this does suggest that Genetics plays a large role in sleep-wake regulation. Here we have common childhood sleep-wake disorders. For instance, insomnia disorder, or more specifically, behavioral insomnia during childhood. That's prevalent in about 10 to 30% of children, affecting males and females equally. It presents as resistance to caregiver designation of bedtime and even difficulty sleeping without intervention from the caregiver. This can just be diagnosed by history. There is also narcolepsy, which peaks at two different variables, the first being between ages 10 to 25 years. Very rarely does narcolepsy present in older adults. We also have obstructive sleep apnea, which is present in about 1 to 5% of children. Onset is usually between 2 and 8 years of age. This might present as snoring, unusual sleep positions, paradoxical breathing. You can have nighttime enuresis from obstructive sleep apnea. Children may complain of waking up with morning headaches. There may be cognitive and behavioral issues that accompany this, daytime sleepiness, and even structurally for OSA, children might have enlarged tonsils or adenoids that need to be removed for treatment. For OSA to be diagnosed, polysomnographic testing is required. We also have circadian rhythm sleep-wake disorder, specifically delayed sleep phase type. That's prevalent in about 7 to 16% of adolescents, and there's a large genetic or familial tie to this, so about 40% of those affected by this have a family history of the condition as well. These patients are called night owls because they have difficulty falling asleep and they have difficulty waking up at socially acceptable times. We also have parasomnias. That includes our NREM sleep arousal disorders, such as sleepwalking or sleep terror type. Sleepwalking is present in about 17% of children, and it peaks between the ages of 8 to 12 years of age. Sleep terrors are prevalent in about 1 to 6.5% of children, with onset in early childhood. We also have nightmare disorder, which is prevalent in about 10 to 50% of 3 to 5-year-olds, And then we have restless leg syndrome, which is prevalent in about 2% of children. And this oftentimes can be diagnosed by history, but is associated with other variables, potentially caffeine intake, or for these pediatric patients, oftentimes it can be associated with use of a stimulant, treating attention disorders, perhaps. So again, remember that sleep disorders in our pediatric population are oftentimes occurring secondary to a different primary diagnosis, so treatment of that primary diagnosis is critical, but also addressing sleep hygiene can be helpful, and that can include behavioral and environmental modifications, that can include CBT as a form of psychotherapy. Reassurance for this child-adolescent age group is huge, especially based on the different presenting sleep-wake disorders. And then if you do need to shift into medication management, melatonin is definitely a first-line option. Antihistamines like hydroxyzine, perhaps. Then you've got your alpha agonists like clonidine, guanfacine, and antidepressants can be used as well. You can utilize trazodone in your pediatric population, and the only thing to watch for with that would be potential side effects of priapism or associated anxiety or irritability in the pediatric population from utilizing trazodone. And then, if necessary, you could utilize amitriptyline at the lowest dose possible. However, just be aware that there is a risk for cardiac implications here, and that can exacerbate restless leg syndrome, especially in your ADHD and OSA pediatric patient populations. And then just always remember to caution any herbal supplements in your pediatric population. I pray this was informative for all of you, and thank you all for listening.